recurrent above the age of 6. Among the asymptomatic patients, CEA versus CAS, the meta-analysis has shown that the patients subjected to stenting had a higher chance of peri-procedural stroke. The asymptomatic carotid surgery trial, second, is the largest vascular surgery intervention trial till date. This has compared the effects of two procedures, CEA versus CAS, on disabling or fatal events, and it has shown that the procedural hazards in terms of disabling or fatal events and fire disabling stroke rates are equal in both the procedures, whereas the non-disabling procedure stroke rates appear to be slightly higher with CAS. Serious complications are similarly uncommon after competent CAS and CEA, and the long-term effects of these two carotid artery procedures on fatal or disabling stroke are comparable. The treatment options in carotid plaque. The recent advances have been made in the treatment of patients with carotid plaque and asymptomatic. At present, the best therapeutic option is now medical. For symptomatic patients, it is better to undergo any procedure. After talking about the CEA and the CAS and the studies, now let us see which are the contraindications for CEA. The contraindications are decompensated heart disease, previous neck surgery or radiation, contralateral vocal cord paralysis from previous surgery, atypical or surgically inaccessible lesion. After CEA, let us see what are the indications for stenting. Stenting has always been the second line of choice for high-grade symptomatic carotid stenosis. The indications are patients who had a lesion that is not amenable to CEA, patients with radiation-induced stenosis, stenosis occurring in the setting of previous CEA, and in patients with significant comorbidities that increase the risk of general anesthesia. There are patients who are at high risk for CAS. We need to identify them. They are patients with visible thrombus at the level of lesion, active infection, inability to obtain vascular access, severely calcified plaque, severely calcified aortic arch, near occlusion of carotid artery, inability to deploy a cerebral protection device, such as carotid artery. Now let us talk about the anesthetic management of a patient coming for carotid endarterectomy. A brief discussion about the surgical procedure. Here in CEA, the carotid artery is circumferentially isolated from above and below the carotid bifurcation. The carotid artery is clamped, the artery is incised, the plaque is removed, and the arteriotomy is closed longitudinally. The preoperative evaluation of a patient posted for CEA, we need to see the medical line of management which is there. This includes beta blockers, statins, and antiplatelet agents. These need to be continued. A poorly controlled hypertension has to be addressed too, and poorly controlled diabetes also requires preoperative optimization. A series of blood pressure and heart rate measurements need to be obtained because this is used to determine the acceptable ranges for perioperative management. Evaluation and range of motion of the patient's neck. So we need to see the range of motion of the patient's neck that is tolerated without any evidence of cerebral ischemia. This will help us to avoid the extremes of extension and rotation of the neck during ventilation, intubation, and patient positioning. Over and above all this, patient reassurance is very important. So we need to counsel the patient. And on the day of surgery, all the patients should be queried regarding any new cardiovascular or cerebrovascular symptoms. After seeing this routine preoperative evaluation, the question is, are there any patients who need further workup? Yes, there are patients who need further workup. These are patients with unstable angina, recent MI, decompensated congestive heart failure, and significant valvular disease. These patients require preoperative studies for the evaluation of myocardial function or ischemic potential. If we have a patient with carotid artery stenosis along with a coronary artery disease, what to do? Prevalence of coronary artery disease in patients with carotid stenosis is as high as 77%. Studies suggest that patients with asymptomatic carotid stenosis are at a higher risk of myocardial infarction than stroke. But the indications for coronary angiography and coronary revascularization prior to elective revascularization of asymptomatic carotid artery stenosis remain controversial. The presence of myocardial infarction or elevation in cardiac biomarkers is associated with a significantly higher risk of subsequent mortality. Keeping this in mind, a particular study was done where the patients were subjected to preoperative coronary angiography and stenting. These were patients who had asymptomatic coronary artery disease. The postoperative results showed that the patients had lesser incidence of MI when they were subjected to preoperative coronary angiography. But the one thing we need to keep in mind is there shouldn't be any delay in the surgery because of the investigations like coronary artery angiogram, etc. And if a patient with coronary artery disease along with carotid artery stenosis is there, there are few studies which have shown that combined or coronary revascularization combined with carotid artery stenting will usually yield favorable results. What are the investigations required in a patient posted for preoperative for carotid artery endarterectomy? The routine investigations: hemoglobin, electrolyte, blood urea nitrogen, creatinine, ECG, chest radiograph, and in patients with COPD and baseline ABG. The goals of anesthetic management: 1. Protection of the heart and brain from ischemic injury. 2. Control of the heart rate and arterial blood pressure. 3. Ablation of the surgical pain and stress responses. And 4th, the most important one, have an awake patient at the end of surgery for the purpose of neurological examination. Preparation of the patient for CEA. The routine monitoring is continued: ECG, non-invasive blood pressure monitor, pulse oximetry, end-tidal captometry, and temperature. One thing we need to know here is all the patients should have an intra-arterial catheter. This is to monitor the blood pressure more closely. The patients usually have a lot of fluctuations in the blood pressure in the intraoperative period. Hence, an intra-arterial catheter is necessary. And who are the patients who require a central venous catheter or a pulmonary catheter? They are the patients who have poor left function, LV function, or who have a severe coronary artery disease. But one point we need to keep in mind is that while placing the central venous catheter in the contralateral jugular venous axis, we need to make sure that we have to keep in mind that if there is an inadvertent arterial or venous puncture, this can cause a hematoma, and this hematoma will compromise the collateral blood flow during carotid cross clamping. The OT, we have to keep ready multiple syringe pumps because we need to give lot of infusions. We need to keep ready. We need to keep ready phenylephrine, sodium nitric oxide for all the hypotension and the hypertension happening in the perioperative period. The anesthetic technique, we have an option of general anesthesia versus regional anesthesia. Let us now see what are the advantages of general anesthesia in patients with carotid endarterectomy. The benefits are, we have a still patient, a quiet operative field, we can have the early control of the airway and the ventilation. We will be able to protect the brain in case there is any ischemia. The disadvantages are, we cannot perform neurological evaluations during surgery. Hence, neurologic function monitoring is mandatory. Regional anesthesia, the advantages are, it allows repeated neurological evaluations. And there are some anecdotal reports which show that regional anesthesia has a greater stability of blood pressure. There is decreased requirement of vasoactive medications and decreased incidence of perioperative MI. The potential complications with regional anesthesia are, patient can have seizures, there can be an alteration of mental status with cerebral ischemia, a loss of patient cooperation with cerebral hypoperfusion, inadequate ventilation, and sedation. So this multi-center trial, which is the most commonly quoted trial, the general anesthesia versus local anesthesia for carotid surgery trial, this included 3,500 patients, and this has shown that there are no definite differences in the primary outcome, that is stroke, MI, or death, quality of life, or length of hospital stay when the patients were subjected to general anesthesia or local anesthesia. Hence, the available literature now does not support the use of one anesthetic technique over another for carotid surgery. General anesthesia is generally routine, but there are few considerations which we need to keep in mind. The arterial blood pressure responses during and after endotracheal intubation are unpredictable in this patient population. Regarding the use of scoline, the hemiparetic patients, there's a possibility of hyperkalemic response. Always maintain normocapnia, and always remember that we need to have an awake patient at the end of surgery. So we will be using short-acting anesthetics. Regarding the use of volatile anesthetic agents, the volatile anesthetics agents always interfere with the neurological monitoring, and as it is mandatory to have a neurological monitoring, we need to keep the volatile anesthetic concentrations less than 0.5 MAC. The depth of anesthesia to maintain, we can supplement with the use of intravenous medications. The arterial blood pressure, this should always be maintained in the high normal range during the procedure, especially during the period of carotid clamping. In patients with contralateral internal carotid artery occlusion or severe stenosis, the BP has to be at least 10 to 20% above the baseline. The emergency and extubation, these are as challenging as the intubation, or actually even more challenging. They're associated with marked hypertension and tachycardia, which have to be kept in mind and have to be tackled and we have to make sure the patient is awake. Here, one study shows that greater hemodynamic stability and decreased pharmacological intervention during emergence is seen in patients undergoing carotid endarterectomy with propofol versus isoflurane. Coming to neurological monitoring, the detection of cerebral ischemia and emboli can be done in a variety of techniques that fall into three categories that monitor cerebral blood flow, cerebral activity, and cerebral oxygen saturation. Cerebral blood flow is monitored using transcranial Doppler or measurement of the carotid stump pressure or the regional cerebral blood flow. Cerebral activity is monitored using EEG, processed EEG, evoked potentials. Cerebral oxygen saturation can be monitored using jugular venous oxygenation or cerebral oximetry. The transcranial Doppler or the Doppler ultrasound is used to measure the flow in the ipsilateral middle cerebral artery. It was used to determine the need for a shunt, and if a shunt is already placed, it will tell us whether the shunt is functioning adequately or not. The transcranial Doppler also helps to assess the adequacy of pharmacologically induced intraoperative hypertensive therapy. It allows the detection of air or particulate embolization. ECDR, it's technically demanding and it may not be obtainable in approximately 20% of the patients. As the changes in flow velocities can be due to changes in arterial diameter or low perfusion, it is not very sensitive or specific for assessing cerebral perfusion. This diagram picture here shows us the TCD before the application of the clamp. During the clamp, you can see the flows are absolutely less. And after once the stent is placed and inserted and is functioning, we can see the flow returning black. In this particular picture, we can see that the TCD has detected emboli during the procedure. The internal carotid artery stump pressure, this is an indirect measure because it measures perfusion pressure and not flow per se. The stump pressure is obtained after the initial clamping of the internal carotid artery. Maintaining a stump pressure between 25 to 70 is necessary to avoid neurological injury. We have to keep in mind that this does not correlate consistently with changes in EEG, regional cerebral blood flow, or changes in the neurological status of the awake. This is measured by injecting radioactive xenon into the ipsilateral carotid artery or IV, and the decay curves are obtained by placing detectors over the area of the ipsilateral cortex supplied by the middle cerebral artery. The measurements are typically obtained before, during, and immediately after carotid clamping. The cerebral activity monitoring is done by the EEG. The EEG is a 16-channel EEG. It's a very sensitive indicator of cerebral ischemia. The changes in EEG during ischemia can be classified as mild, moderate, or severe. The severe EEG changes are more than 50% decrease in the waveform amplitude in a generalized or lateralized distribution. EEG is an indicator. These severe changes in EEG show that the brain may be at risk for infarction. These similar changes are also seen in hypothermia, hypocarbia, hypoxemia, and deep anesthesia. So these can mimic ischemia and we may get wrong results. The equipment required is very bulky. Another problem with EEG is we need specially trained personnel for interpretation. In this diagram here, we can see the cerebral blood flow as it is decreasing from 35 to 12 to 18 ml per 100 grams. We can see there's an increase in the slower frequencies. As we come down to less than 10, there is total suppression. This picture shows us the EEG before an ischemic event, during an ischemic event, and during recovery. We can all understand that it's really complicated to understand this. Hence, we have come up with this processed EEG. Here, the equipment is more compact and the data display allows us for ease of the interpretation. An example of this processed EEG is the BIS monitor or the bispectral index monitor. It's commonly used by us to assess the depth of anesthesia, and it is unreliable as an indicator of hemispheric cerebral ischemia during carotid cross-clamping. Evoked potentials. The somatosensory evoked potentials and motor evoked potentials are monitors of the cortex and the subcortical areas. Any change in the median nerve somatosensory evoked potentials during CEA is a sensitive marker of the ischemia in the middle cerebral artery. Tibial nerve somatosensory and motor evoked identify ischemia to the anterior communicating artery and the subcortical territories. The evoked potentials have a regional nature. Hence, any lack of change in evoked potentials does not guarantee that the patient will emerge from anesthesia free from neurological deficits. Evoked potentials are used in combination with transcarotid Doppler EEG monitoring to improve detection of cerebral ischemia and need of shunting. The cerebral oxygen saturation monitoring is done by jugular venous oxygenation measurement. This measures the oxygen saturation within the jugular vein, which is normally between 55 to 75%. Any decrease in the baseline value will indicate an ongoing ischemia. The limitations to this particular procedure are it gives a global monitor of the cerebral perfusion, and in the jugular bulb, there may be mixing of the extracerebral blood, so we will not get a correct reading, and the placement of a catheter into the jugular bulb may result in jugular vein thrombosis. Cerebral oximetry, this uses near-infrared spectroscopy to measure oxygen saturation of the cortex. Two adhesive pads are applied to the forehead and baseline oxygen saturations are obtained from the right and the left hemispheres. These values are followed and trended intraoperatively. As of now, there is no established criteria with this monitor to guide shunt placement or any other therapy to prevent post-op neurological deficits. This picture shows us how these pads are kept over the forehead, and we can see the readings in the right side in the monitor. Coming to regional anesthesia for carotid endarterectomy, it can be obtained by blocking the C2 to C4 dermatomes. We have the option of blocking this using a superficial, intermediate, or deep cervical plexus block. Comparing the superficial and deep, the deep cervical plexus block has shown that there is a higher serious complication rates, and the conversion rate to GA is also higher in the deep block from many systematic reviews. Hence, the superficial cervical plexus block is preferred. The four cutaneous branches of the cervical plexus emerge from behind the sternocleidomastoid at its midpoint. They supply the area of from the clavicle to the jawline anteriorly and to the mastoid process posteriorly. The classical superficial cervical plexus block involves subcutaneous infiltration of 5 to 10 ml of local anesthetic along the posterior border around its midpoint. Supplemental infiltration of local anesthetic by the surgeon, especially at the lower border and the ramus of the mandible, is very useful. This diagram shows how the nerves are emerging from behind the sternocleidomastoid at the midpoint. Cervical epidural anesthesia, this is not very commonly used or not very popular, except in few countries, especially in France, it has been used. They use the midline approach and they use the hanging drop. 10 to 15 ml of 0.5% bupivacaine with or without fentanyl is used. The problems are hypotension, bradycardia, and the dural puncture rate is 0.5%. Respiratory failure requiring intubation occurs in around 1% of the patients. The post-operative complications in a patient undergoing carotid artery endarterectomy is neurological complications, 1 due to intraoperative embolization or hypoperfusion, and 2 due to intraoperative or intracerebral hemorrhage or hypoperfusion. Hypotension and hypotension at the end because of carotid sinus baroreceptor dysfunction, recurrent laryngeal nerve, superior laryngeal nerve or hypoglossal nerve injuries, and a wound hematoma. Now briefly we'll talk about the carotid stenting and the anesthesia. Carotid artery angiography and stenting is 4 steps: percutaneous arterial access, angiography, placement of an embolic protection device, and stent placement. This particular procedure is usually performed with the patient awake or under mild sedation. Anesthesia for the TCAR procedure. This is a novel hybrid surgical modality in treating carotid stenosis. The transcarotid artery revascularization was introduced as an alternative to CAS. It eliminates the risk of aortic arch manipulation by directly accessing the carotid artery proximal to bifurcation. There's a reversal of the arterial flow from the carotid to the femoral vein, and this is employed for neuroprotection and minimizing the risk of stroke. The procedure involves dissection of the common carotid artery with the insertion of a sheet which stays proximal to the carotid bifurcation. This carotid sheet is connected to the femoral vein sheet through a shunt which has a filter device. To establish a reversal of flow, the common carotid artery is clamped proximal to the insertion of carotid sheet. The femoral vein, because it is low in pressure, the blood starts to flow from the reverse direction, that is from the brain to the ICA to the femoral vein. This blood flows to the shunt, and there is a filter which will collect the plaque or the thrombotic debris. Hence, the patient, there is less incidence of perioperative stroke. As this reversal of blood flow is going on, the lesion is crossed with a wire and treated with angioplasty and stenting. TCAR procedure can be performed under general anesthesia, regional anesthesia, or monitored anesthesia care. The advantages of general anesthesia are we have optimal surgical conditions with patient positioning, immobility and secured airway, controlled ventilation and oxygenation. When we do under regional anesthesia or MAC, the advantages are we have a reliable neurological monitoring. There's a decreased sympathetic stimulation associated with airway manipulation and minimizing cough during extubation. So to summarize, anesthetic management of carotid artery disease requires CEA or CAS is always challenging. Firm evidence for the best anesthetic technique has yet to be published. Excellent communication between the anesthesia and the surgical team throughout the procedure is necessary to ensure appropriate cerebral perfusion. A systematic approach to vascular access and hemodynamic and neurological monitoring is necessary to minimize the risk of post-operative hemorrhage or perfusion. These are my references. Thank you.
Thank you, Lavanya, for your exhaustive presentation. Guru sir.
Yeah, just came home.
Yeah,
Lavanya, it was an excellent presentation. You covered most of the thing regarding anesthesia for carotid endarterectomy, from the anatomy till the regional anesthesia that can be used for these patients. It was very nice. And, you know, if any of the postgraduates are there, definitely they can definitely take many of the knowledge that you have already given, because, you know, it is commonly asked as a 20 marks question for, it used to be asked. Now, of course, RGHS, now it has got only 10 mark question. Definitely DNB and MD and DA, this 10 marks question is always asked regarding carotid endarterectomy. So very well presented. So one thing I just want to add here is that, you know, what is most important in these patients is the pre-anesthetic evaluation. So because as you have already told that many of these patients will also have associated the coronary artery disease, very common. So because the coronary artery disease is there, so naturally you have to really go into details about the pre-anesthetic evaluation, whether they have already had a coronary revascularization procedure, And if they had a stent, definitely, dual antiplatelet therapy, that problems are always there. And second thing, also you said that, there is always, the debate is still going on whether if they also have a coronary artery disease and also they require a carotid endarterectomy, which one to be done first? Should they have to be subjected for revascularization procedure or a CABG, and then they have to be taken up for carotid endarterectomy, or you directly go for carotid endarterectomy and then go for the revascularization procedure? So that debate is still going on. But if we subject them for CABG, because many of these patients can have a triple arterial disease of coronary arterial disease. So if they are subjected for CABG, definitely it itself carries a very high risk just for taking these patients for carotid endarterectomy. So that is always there. One can go for procedures like, as you said, that stenting also can be done for these patients when they have a triple coronary arterial disease. So one other thing also is that these patients can be on antiplatelets. So dual antiplatelet therapy is very common in these patients. So if they have a dual antiplatelet therapy, so again, in pre-anesthetic evaluation, so you'll have to decide whether should we stop, when to stop, all those problems. So if they have had a stenting, then should we have to postpone the surgery of for more than 3 months? If it can be postponed, definitely it should be postponed for 3 months. Then only they have to be taken up, because you cannot stop the dual antiplatelet therapy within 3 months after subjecting these patients for coronary stenting. So that is one more thing. The other thing is, many of these patients are obese patients, and you will have a difficult airway. So that also has to be attended to. I think Srinivas, able to hear me?
Yes, sir. We can hear you.
Yeah. So majority of these patients will have obesity is very common in these patients with carotid arterial disease. So again, a short neck and the positioning itself is a problem. And for us, again, in laryngoscopy and intubation is a real problem. So the other thing again is the intubation response, so laryngoscopy and intubation response, because they have two problems. One is they have a decreased blood flow to the brain, and they have a decreased blood flow to the myocardium also, because coronary artery disease is very common. So you have to take care during laryngoscopy and intubation. So the other problem again is intraoperatively, we know that the surgery is very close to the the carotid sinus. So because it is very close to the carotid sinus, we have had 1 or 2 incidences of bradycardia, severe bradycardia, and even there are case reports where arrests have occurred. Of course, we had one arrest recently that was not for carotid endarterectomy, but the laryngectomy was being done. And because as the surgeon was very close to that carotid sinus, we had an arrest, and then we could resuscitate the patient. So this is another thing which one has to keep it in mind. So again, combination of regional anesthesia with general anesthesia. Maybe that's what we practice in our hospital. We give superficial cervical plexus block, and then we give a GA for these patients. So that also we have found that it suppresses even the intubation response. Once you give bilateral superficial cervical plexus block and then go for the the laryngoscopy and intubation. So we have found that the suppression of the intubation response also will be there. So monitoring, as you said, that very important, neuro monitoring they'll be doing. So naturally, you may not be able to use your routine concentration of inhalation anesthetic agents. So because they'll definitely suppress these evoked potentials, both latency can be depressed and then the amplitude can be depressed. So that is another very important thing. You highlighted that also, that you cannot go more than 0.5 max. So better to go for, I think, intravenous continuous infusion of the opiates and also the propofol definitely can maintain a good depth of anesthesia, which is very, very important. Overall, excellent discussion of carotid endarterectomy you have done. And thank you, Lavanya. Thank you so much.
Thank you, sir. Thank you so much.
Yeah.
So one more thing, Lavanya, we used to talk about this VAA test with terpentol.
Sir?
VAA test, VADA, VAA test. So with tap and tone before subjecting these patients for carotid endarterectomy, just to know whether the perfusion to the brain, that side of the brain, whether it is adequate perfusion is there or not. So they used to be given tap and tone, and then tap and tone produces cerebral vasoconstriction. That is always there because it also decreases the CMRO2, it also decreases the cerebral blood flow. So with that, they used to monitor the cerebral blood flow of either side, and just to see if there is already a decreased blood flow, there may be further decrease in blood flow of that particular that side of the brain. So that was also called as a VAA test. Of course, nowadays we are not doing this VAA test. So sometimes the student may be asked about VAA test. So that you did not highlight it because we don't do it nowadays. But whenever we talk about tap and tone, this one of the uses of tap and tone is used in VAA test.
Thank you, sir.
Okay.
Any specific inhalational agent is preferred, Lavanya?
Sir, actually, they have shown that isoflurane is as good as sevoflurane. So these two are preferred, sir, isoflurane and sevoflurane.
This is because of the vasodilatation effect of.
So the effect on the regional cerebral blood flow and the critical cerebral blood flow, the effects on that.
Yeah, like ISO, they say produces coronary steel and all. So in the similar way, is there anything in the central nervous system also that is carotid circulation? So no, usually they discuss about the steel phenomena with isoflurane.
Yes, sir. Yes, sir.
Only theoretical, sir. It's only theoretical, sir.
Yeah, that's why I'm asking, just for the benefit of our students. Like that. Sir, sir.
Yeah, no, that that is mainly in myocardium and coronary circulation.
Coronary.
There is a theoretical possibility of isoflurane producing coronary steel because it diverts the blood from stenosed area or ischemic area to the normal area. But this is not a possibility in
the central nervous
patients. Cerebral carotid endarterectomy procedure. That should not be a problem. And another thing is we don't use the full mark of isoflurane or sevoflurane or desflurane. So we go for even 0.5 mark because of their effect on the neuro monitoring of these patients during the surgery. So otherwise, actually, use of inhalation anesthetic agent is very important because they are organ protective. So at least 0.5 mark you should always use. They have very good organ protective property. So that's how it is always used, but less concentration. Of course, combined with regional anesthesia plus opioids plus IV anesthetic agents. So that is a very good balanced anesthesia technique we can continue to manage in these patients.
So anybody wants to add anything to the knowledge? Sudesh?
What is the drug used for increasing the blood pressure continuously? Phenylephrine. Apart from that, how do you maintain the MAP continuously? IBP monitoring is a must, sir, but
IBP monitoring is a must, sir, because there are a lot of fluctuations, and invasive blood pressure, arterial blood pressure, we'll be able to detect it early and manage it better.
Lavanya, one more thing you did not talk about is the fluid management.
Sir, yes, sir.
So what about fluid management in these patients?
Not able to hear some network problem.
The fluid management is around 10 ml. We have to be conservative, 10 ml per kg, and not more than 1 liter because the procedure also is short. We should not overload the patients because they usually have a coronary artery disease also. So if there is an overload, then we'll be subjecting them to more stress on the myocardium.
No, it again, it depends on the severity of the disease also. They have associated comorbidities like diabetes, maybe there,
Carrier.
hypertension, then coronary artery disease. There, multiple problems always will be there. As you said that you always go for an invasive monitoring also. An arterial line is always there. So if you have, monitors like flow track, so you can just connect this flow track to direct arterial line, and you can definitely go for a goal-directed fluid therapy in these patients. So of course, conservative fluid management or a restrictive fluid management is fine, but definitely if you can go for a goal-directed fluid management, you don't have to worry as far as hypotension is concerned, because Dr. Kulkarni was asking, how do you maintain the mean arterial pressure to a slightly higher level? That is very important, because any hypovolemia can produce hypotension intraoperatively. So fluid management becomes very important. So you can definitely go for stroke volume variation or pulse pressure variation or systolic pressure variation, any of these things. Or if you have a pulse oximeter, which can also monitor the pleth variability index, you can also go for these. So dynamic monitoring is very important in management of fluid status. And ideal fluid again is a balanced fluid, balanced salt solution can be an ideal fluid in these patients. So that also have to be kept in mind, because any fluid, extra fluid, if you give, there can be a lot of problem in these patients. But decreased amount of fluid again can produce hypotension, and you said that hypotension to be avoided.
Yes, sir.
Yeah.
Sudhi, you want to add something? Good evening.
Yes, sir. Nothing, sir. Good evening, sir. Good evening, Gurudev, sir.
Good evening, Suresh.
Yes, sir. As you were discussing regarding carotid sinus compression and the bradycardia and arrest, actually, when we were PGs there, during those 2005, 2006, there was oncosurgery, this one going on, like workshop going.
Okay.
This radical neck dissection. So that surgeon was going, sir.
Yeah, tell me, Suresh.
Yeah, the surgeon was going close to the carotid sinus. Of course, it was not for carotid endarterectomy, and he went twice, thrice, and there was significant bradycardia. Then what we did was we dipped lignocaine, dipped pledgets. We just placed there for 5-10 minutes, and then he was doing the surgery. And after sometimes, even after the pressures, it was not causing that much of bradycardia. So that actually solved the problem. Under GA, we didn't, fortunately, we didn't require to deepen the plane of anesthesia. We could maintain the patient at that plane itself. Of course, we didn't have depth of anesthesia monitor those days, but definitely the patient was quite stable at that point of time, sir. So that is one thing what we can always think about. I think so. On that day, in fact, we had a discussion also, and you were there, sir. And you also suggested sometimes installation of lignocaine there.
Yeah, around by the surgeon himself. He can
by the surgeon himself, sir. Exactly.
At the branching of the carotid artery, common carotid artery into right and internal and external. Yeah, around that, because carotid sinus is there, so one can infiltrate. So
yes, sir. Yes, sir. That's what. In fact, you made them do also.
Yeah.
The next day they did the same thing, and we didn't have any problem. Yes, sir. Thank you, sir.
Yeah. There are no more questions. I think we'll go to the next lecture, sir.
Okay.
Sir?
Right.
Yeah.
Sure.
So I request Dr. Meha to share a screen and start the presentation. Cervical plexus block, innate to high risk and head and neck surgeries. Dr. Meha.
Yeah, I'm just sharing.
Yeah.
Screen.
Yeah, sure.
Good evening to all my beloved teachers, seniors and friends. After an extensive lecture by Lavanya ma'am, I hope I'm living up to that. So here I'll be talking about cervical plexus block and innate to high risk head and neck surgeries. I'm basically talking about how the cervical plexus block is performed, the anatomy and how it is performed, and a few cases that we have managed at Apollo. I'll be talking about that. So going forwards, Cervical plexus anesthesia was developed in the early 20th century. Two main approaches that were used: the posterior approach and the lateral approach. In 1912, Kapis described a posterior approach to cervical and brachial plexus, which attempted to block the nerves at the point of emergence from the vertebral column. In 1914, Heidenheim described the lateral approach. 1920, Victor Porsche described the lateral approach and recommended it over the posterior approach. Vinny in 1975 described a simplified single injection technique via the lateral approach to cervical plexus. The indication for cervical plexus blockade: superficial surgeries in the neck area, including lymph node dissection, excision of thyroglossal or branchial cleft cysts, carotid endarterectomy, and vascular access surgeries, and for anesthesia and post-op analgesia for head and neck surgeries. Contraindications: patient refusal, local infection, previous surgery or radiation therapy to the neck, as it would have distorted the anatomy of the area, and patients with contralateral phrenic nerve palsy, as there is always a chance of blocking the ipsilateral phrenic nerve with the cervical plexus blockade. Cervical plexus anatomy. The cervical plexus is formed by the anterior divisions of C1 to C4 nerves. The plexus is basically situated on the anterior surface of the upper four cervical vertebrae. It rests on the levator angulae scapulae and the scalenus medius muscles. It is in front covered by the sternocleidomastoid muscle. The first cervical root, the C1 nerve root, is basically a motor nerve, so it's not much of importance in case of the renal anesthesia. And the anterior rami of the second to fourth cervical nerves, they form the cervical plexus. Here we are seeing that this is the sternocleidomastoid muscle. The crossover of the external jugular, that's where the cervical, the superficial branches are emerging. The clavicle. The superficial cervical plexus, it innervates the skin and the superficial structures of head, neck, and shoulder. The terminal branches of the superficial cervical plexus, that is, they are the cutaneous branches. There are four distinct nerves that emerge from the posterior border of the sternocleidomastoid. That is the lesser occipital nerve, greater auricular nerve, transverse cervical nerve, and supraclavicular nerve. So here we see the distribution of the specific nerves. The supraclavicular nerve here, transverse cervical, the lesser occipital, and the auricular. The deep cervical plexus innervates the deeper structures of the neck, the muscles of the anterior neck, and it gives a branch to the diaphragm, which is the phrenic nerve. C3, 4 send a branch to the spinal accessory and they innervate the trapezius muscle. And C4, 5 further participate in the formation of brachial plexus. These are the cutaneous branches that we see here, and these are the further branches, the phrenic and the muscular branches. So while performing the block, we need to identify and mark these anatomic landmarks. The first one is the mastoid process. The second is the Chassenac tubercle. The Chassenac tubercle is the transverse process of the C6 vertebra. It is palpated behind the clavicular head of the sternocleidomastoid at the level of the cricoid cartilage and the posterior border of the sternocleidomastoid muscle. So here we see the marking. This is the mastoid process, the C6 Chassenac tubercle, and the line. This happens to be the sternocleidomastoid, the line, the posterior border of the sternomastoid. So we are joining the mastoid to the C6. This is the line which is joining it. Then the site of needle insertion is basically the midpoint of this line. This is where the branches of the superficial cervical plexus emerge from the posterior border of the sternocleidomastoid. So technique of the superficial cervical plexus blockade: after sterile aseptic precautions, a skin wheel is raised at the site of needle insertion using a 25 gauge needle. A fan-shaped technique is used for the deposition of local anesthetic at the posterior border of the sternomastoid, and then you go step-led and caudal in 3 directions. It usually requires 10 to 15 ml of local anesthetic in total, 3 to 5 ml per redirection or per injection. These are the directions in which we go. First is at the midpoint, then we directed caudal, and then cephalic, which blocks the the four cutaneous branches. Now for the deep cervical plexus blockade, as we saw the line joining the mastoid process to the chastinate tubercle, which is drawn, and then we are supposed to label the respective vertebral levels, which are at from the mastoid process. They are at 2, 4, 6 centimeter respectively. That corresponds to C2, 3, 4, 5 vertebral levels. A deep cervical plexus at each level requires 3 to 5 ml of the local anesthetic. After sterile aseptic precautions, after subcutaneous infiltration of the local anesthetic, firstly the needle should the insertion should be perpendicular to the skin, and it should contact the posterior tubercle of the transverse process. And once it contacts the transverse process, it has to be withdrawn about 1 to 2 ml, and then after negative aspiration for blood, the 3 to 5 ml of local anesthetic is injected, and then it's withdrawn, and then the same thing is repeated at the next level. Like I said, the same thing. Transverse process is typically contacted at a depth of 1 to 2 centimeters in most patients. It is advanced slowly until the transverse process is contacted. Then the needle is withdrawn 1 to 2 ml, stabilized, and then after negative aspiration for blood, 3 to 5 ml of the local anesthetic is injected, and it is then repeated at consecutive levels. Ideally, we should never advance the needle beyond 2.5 centimeters due to the risk of spinal cord injury. This is the expected sensory distribution with the cervical plexus blockade. Now coming to the ultrasound guided technique of the cervical plexus blockade. Before going for the ultrasound guided cervical plexus blockade, we need to know about the neck, the fascia which are covering the neck, layers of fascia. So the cervical fascia, there is a superficial cervical fascia, which is nothing but the subcutaneous layer, which is basically this part. This is the subcutaneous superficial cervical fascia. Then there is the deep cervical fascia, which is further divided into superficial, middle, and deep cervical fascia. The superficial fascia is the investing layer of the deep cervical fascia, which encompasses the sternocleidomastoid muscles. This is the investing layer of the deep cervical fascia. Then we have the visceral fascia or the pretracheal fascia, and the prevertebral or the paravertebral fascia, which is the deep part of the deep cervical fascia. So when we are administering the superficial cervical plexus block, it is outside, it is basically in the subcutaneous plane. It is outside the investing layer of the deep cervical fascia. The intermediate cervical plexus block, the injection is in between the investing layer of the deep cervical fascia and the prevertebral fascia. And when the injection is deep to the prevertebral fascia, it is the deep cervical plexus blockade. So this is what we discussed. In the ultrasound view, the sternocleidomastoid forms the roof of the nerves of the superficial cervical plexus, and the plexus are usually visualized as a small collection of hypoechoic nodules or honeycomb appearance, deep or lateral to the posterior border of sternocleidomastoid. This is the cervical plexus transverse view. Here we see this is the sternocleidomastoid muscle. This is the investing layer of the deep cervical fascia. This is the middle scalene, anterior scalene muscle. In between this is the cervical plexus. So the position of the patient should be either supine or in sitting position with head slightly turned away from the side to be blocked. Both in plane and out of plane approaches can be used as the target is at a shallow position of 1 to 2 centimeters. So technique of ultrasound guided blockage. After aseptic precautions, The transducer is placed on the lateral part of the neck, overlying the sternocleidomastoid muscle at the level of its midpoint. The transducer is moved posteriorly or laterally until the tapering border of the posterior border of the sternocleidomastoid is visualized in the middle of the screen. Right underneath it will be the investing layer of the deep cervical fascia, and underneath it we will be seeing the cervical plexus. Beneath that, we have to identify the interscalene groove, which is in between the anterior and midscalene muscle. Over it and underneath the sternocleidomastoid will be the cervical situation of the cervical plexus. So the needle has to pass through the skin platysma and the investing layer of the deep fascia, and the tip should be placed adjacent to the plexus. After negative aspiration, 1 to 2 ml of local anesthetic is injected to confirm the proper injection site, and the remainder of the local injection is administered to envelop the plexus. So this is the ultrasound view, the sternocleidomastoid, middle scalene, anterior scalene. Here we see the carotid artery. This is the medial entrance. The local anesthetic phase. This is the longitudinal view of the same. Coming to the complications of the cervical plexus blockade, infection which can be avoided by sterile aseptic precautions. Hematoma usually occurs if at all there is any inadvertent injury to the vascular structures. Phrenic nerve blockade is one of the known complications of the cervical plexus block, and hence it is contraindicated in patients who have a compromised contralateral phrenic nerve. And local anesthetic systemic toxicity and intrathecal injection. Coming to the cases that we have managed using the cervical plexus blockade. Firstly, there was this 93-year-old lady. She was a known case of diabetes, hypertension, and ischemic heart disease. Had undergone coronary stenting, the details of which we didn't know. History of stroke about 6 months back, was at the right MCA territory. She had a left hemiparesis. She was hospitalized for about a week and she recovered completely without any deficit. She was put on dual antiplatelets post the stroke, and after 2 months of it, she came back to the hospital with 2 episodes of GI bleed. She had melena, and after endoscopy was done, and then she found to have some GI bleed, and then endoscopic gastric banding was done. Then after that, again, she had another episode of stroke and hemiparesis about 2 months back. Medically managed. She didn't have any deficits this time too, luckily. Then she underwent a carotid Doppler. Carotid Doppler showed right internal carotid artery stenosis about 80%. This lady was posted for a right carotid endarterectomy. To the next patient. This was a 65-year-old lady. She was a known case of diabetes, hypertension, hyperparathyroidism. She was on serial calcium and parathormone monitoring. She gave history of elevated levels of both calcium and parathormone for the past few months, with bone pains, generalized weakness, and asymptomatic gallstones. She was a known case of interstitial lung disease, Sjogren syndrome. She was on tablet Visalone. PFT spirometry showed that she had severe restriction. Sesame B scan was done, which showed that she had right superior parathyroid adenoma. She was posted for excision of right superior parathyroid adenoma. Then the next gentleman, he was a 76-year-old man. This was done just 2 days back on Thursday. He was a known case of diabetes, hypertension, coronary artery disease. He underwent coronary angioplasty, 2 stents to left circumflex and right coronary artery in 2003. He had a CT chest done, which showed he had a large partially thrombosed saccular aneurysm of the arch of aorta, which was distal to the origin of left subclavian artery. No evidence of dissection. Also, he had centrilobular emphysematous bullae in the right middle lobe and bilateral central bronchiectasis. Spirometry showed mild restriction. Lab investigations were normal, echo normal. Surgical plan was thoracic endovascular aortic repair with carotid to subclavian bypass. Now, coming to why we chose cervical plexus block as an anesthetic plan for each of these patients. For the carotid endarterectomy lady, we wanted to monitor her motor function and during the carotid clamping. So that's why we chose the regional anesthetic as the plan of anesthesia. So we were continuously monitoring the patient's motor and this verbal response also. Then the next, this lady, the one who was posted for parathyroid adenoma excision, since she already had a compromised respiratory function, we decided to go ahead with cervical plexus blockage for this lady. Then this gentleman, the same thing again. There would be a carotid clamping done for this bypass procedure as well. So we had to monitor the cerebral function, the motor, and the verbal response. We monitored it throughout the carotid clamp duration. Also, since he had a bulla, emphysematous bulla in the middle lobe, we thought general anesthesia with intermittent positive pressure ventilation might lead to a rupture of the bulla. So this was a video of the intermediate cervical plexus block that we performed. Sternocleidomastoid, investing layer of the deep fascia, the prevertebral fascia, the scalene, the needle injection. You can see the pulsating carotid there. And we see the local anesthetic being injected. So this is an intraoperative video of how we monitored the patient's motor function. The white thing in the surgeon's hand is the graft. The carotid clamp was on, and we were monitoring the motor function with the help of this squeezy toy, which was actually already also making noise. So we could monitor the motor function of the patient. So this was the aneurysm, with MRI image of the aneurysm. This was the saccular aneurysm. This was the origin of the left subclavian. They had decided to stent this part of the aorta, and the subclavian had to be bypassed before that because the circulation of the subclavian would be cut off otherwise with the stenting. This is post the procedure. This is the stent in place. So in conclusion, I would like to say that cervical plexus block is a powerful tool in the hands of the anesthetist for the management of high-risk head, neck, and vascular surgery. These are my references. Thank you very much for your patience listening.
Thank you, Mehajabeen. It was a wonderful presentation and well compiled and well presented. Good, sir.
Really have to appreciate Dr. Meha. So she presented this particular lecture very well, excellent presentation. Plus, addition of that video definitely, made it more interesting. Plus that case series, 3 patients, very difficult patients, probably if one has to go for to do the whole procedure under GA. So definitely, in such situations, deep cervical plexus block with superficial cervical plexus block would be an ideal thing. Just one question to Dr. Meha. So what sedation was used, when this patient, you showed one of the patients wherein she was also, using her hand to squeeze the bulb so that wanted to see for the cerebral circulation. So any particular sedation you were using for
we had put the patient on dexmedetomidine for sedation, sir. Initially, we had started off with a good dose. And when we were approaching the carotid clamp time, we tapered down the dose so that the patient was awake during that 25 minutes of the carotid clamp, so that we were monitoring the patient awake and, the squeezy toy, whatever you saw. And after that, for the further procedure, he was again sedated back.
Yeah, because, I thought so that because, dexmedetomidine is one of the most popular drug that is used for even awake craniotomies also. So we routinely use dexmedetomidine for even awake craniotomy in our hospital. An excellent drug. But in these patients, lying down in that particular head turned to one side for a long time may be a problem unless you properly sedate. So I think a combination of dexmedetomidine with small dose of midazolam and continuous infusion of fentanyl also, I think would definitely work. I don't know whether you were using infusion of fentanyl also.
We were not using infusion. We were using small boluses of fentanyl midazolam along with dexmedetomidine.
Yeah, because that is required. So though we had given, you would have given very good the deep cervical plexus block and the superficial cervical plexus block also, some amount of pain can still be there for the patient. So that's how, opioid combination is also important along with dexmedetomidine. So very nicely presented. So, but you were, talking about the deep cervical and superficial cervical plexus block for carotid endarterectomy. Of course, these cervical plexus blocks are also used for other procedures also, especially, clavicular surgery, we always combine with an interscalene block and superficial cervical plexus block. So majority of the clavicular surgeries we are doing with these blocks only. And, superficial cervical plexus block, many times it may not require even an ultrasound guidance also, because it is such a superficially placed plexus just comes out of the midpoint of the posterior border of the sternocleidomastoid. So just, you just have to see where is the posterior midpoint of the posterior border, just infiltrate there and all along the posterior border, the sternocleidomastoid, I think it will work. So in one of your figures, you showed that, the anterior part of the lower part of the external ear has a mandibular nerve distribution. But what we have seen is it's great auricular nerve and the branch of superficial cervical plexus block, plexus, great auricular along with the lesser occipital supplies the lower half of the external ear, that is a pinna. So for any surgeries of the ear lobule, especially many of the plastic surgeries are done and the ENT surgeries are also done for the external ear, where we used to give and we are giving now also that the great auricular with lesser occipital nerve block, just a V-shaped subcutaneous infiltration of local anesthetic from the just about 2 centimeters below the ear. So anteriorly and posteriorly. I think it would give very good analgesia and anesthesia for the lower half of the ear. So local infiltration at the ear lobule can distort the anatomy there. So that's how this would definitely work. But in your one of the figures you showed, the mandibular nerve supplying the lower part of the anterior part of the ear. So can you just give some explanation for this? Or
Were all picked up from Nisora, sir.
okay.
So,
Now maybe I think overlapping will always be there.
Overlapping,
But what we have practically seen is that greater auricular with lesser occipital block is more than sufficient to for surgeries of the lower half of the external ear. So that is one thing. And another thing I just want to tell about when we are going in for the landmark technique for superficial cervical plexus block. So sometimes we also infiltrate underneath the midpoint of the sternocleidomastoid. But many times, you have to be extremely careful before injecting. You have to aspirate because the internal jugular vein is always there, very close by. So I have had 1 or 2 times when I aspirated, my needle was already in the internal jugular vein. So that has to be kept as a caution. The other one, the landmark technique as far as deep cervical plexus block, which you showed, your needle has to be slightly caudal all the time. Never go perpendicular to all planes. When you are trying to encounter the transverse process, because we have to encounter the transverse process. So withdraw the needle about a few millimeters, about 5 millimeters, and then you have to inject. So during that thing, always keep slight caudal direction because your needle may automatically enter in between the transverse processes. There, the vertebral artery is there. The chance of injecting into the vertebral artery is always there. And another problem is the epidural injection or intrathecal injection can occur. I think that is what the Vinny always says. You said that Vinny's approach. Vinny always says slight caudal direction of the needle, slight, maybe about 10-15 degree caudal direction will definitely prevent this injecting into the vertebral artery or into the intrathecal or epidural space. Otherwise, overall, it was very nice presentation. Thank you, Dr. Meha. Thank you very much.
So, I think most of these patients will have stellate ganglion block also, coexisting.
Exactly. When you go for deep cervical plexus block.
Deep cervical plexus block.
Stellate ganglion is C8T1. So because you will be depositing slightly larger volume, so invariably it can produce Horner syndrome also. That is there.
Yeah. So anybody want to add any comments or your experiences to share with Sudesh?
Can we use this for post-op analgesia of thyroid surgeries? Bilateral superficial cervical plexus
block.
Yes, sir, it can be used. In fact, at least we were using it, and we were giving the superficial cervical plexus block unilateral only. We never gave bilateral, if I remember. And we have noticed when we used to give general anesthesia, we used to have rock solid hemodynamics. No variation at all. The heart rate would be static at whatever we started.
Even thyroid surgeries can be done under regional anesthesia.
Regional anesthesia.
And for that, the indications for patients are, it has to be an hemithyroidectomy, a small thyroid nodule, and the patient, if the patient also has hyperthyroidism, it should be well-controlled hyperthyroidism.
Yeah.
So such are the patients one can go, because the position adopted for thyroid, in that position, the patient will not be able to lie down for a long time, even though your deep cervical and superficial cervical plexus block has been excellent as far as the success rate is concerned, but still the patient has to lie down in that particular position for a long period. So that's how, nowadays hardly we are using these regional anesthesia for thyroid surgery. But as Dr. Srinivas, you suggested, bilateral cervical, superficial cervical plexus block, definitely before surgery itself. Because what we used to ask the surgeon is, we used to ask the surgeon to infiltrate line of incision before he puts a knife. But many of the surgeons never wanted to do this because they used to say that it will distort the anatomy there, and neck is being a cosmetic disfiguration can occur.
And some are feared about infection. They say it can
Yeah.
They cause infection. Maybe
So in all
because of,
those patients, actually we
Yeah,
used to go for, actually I had given a dissertation also to one of my students for all thyroid surgeries, bilateral superficial cervical plexus block. So for intraoperative and postoperative analgesia, it was excellent actually. So that is another indication for superficial cervical plexus block, definitely.
Sir, actually we did a study, sir, comparing incision line infiltration and bilateral superficial cervical plexus block, and published it. But yeah, as you mentioned, the only difference we found was many of the surgeons didn't want incision line infiltration.
Yeah, they are reluctant.
They are reluctant.
But they were happy with superficial cervical plexus block, and they said, as long as you're away from the site of incision, we are fine with it. So we had to do certain cases with certain surgeons, and that was the problem.
Actually, in my study, it is also reduced the anesthetic requirement also, sir. Consumption has come down by 2 ml. That is also published in Korean Journal in 2018. Same article. It was presented in ISACON also and published in 2018 Korean Journal of Anesthesia. Sir, regarding this one, as you said, sir, actually deep cervical plexus block is rarely practiced these days because most of the time the risk of deep cervical plexus block, the phrenic nerve palsy and recurrent laryngeal nerve injury has occurred. That is also one thing what we have noticed in one of the patients. And regarding superficial cervical plexus block, there is one problem what we have noticed in my study, sir, that it results in hoarseness of voice in the postoperative period. But it is very difficult to say, is it because of the recurrent laryngeal nerve involvement? But when we saw, it was actually the external laryngeal nerve which was blocked, sir. And there are case reports which have reported inadvertent blocking of external laryngeal nerve due to the drug seepage along the plane. So that is why they warrant that you should be mindful about the volume of the drug what you are using.
Correct.
So that is one thing. Actually, after that, in fact, the third case which I did during my study developed a hoarseness. So when I went back and went through the literature, then I had to change my methodology, sir. I had to come down on the volume. After that, it was doing well. There was no significant difference in the observation, but definitely the complication at least reduced. So
because external laryngeal supplies the cricothyroid muscle, and it is the principal tensor of the vocal cords. So natural motor paralysis or not. But you suppose if you think that regional anesthesia is benefits are much higher than the general anesthesia, you can safely give central